Good afternoon, everyone. My name is Preetha Aravind. Yes. My name is Preetha Aravind. I'm one of the research fellows at Eric Abayaji's team in Imperial College London. Today, I'll be presenting about the Exemplar 1 study, which is fluoropivalate or FPIA in solid tumors. Now, the role of fatty acid metabolism in tumor initiation, in progression, and the therapeutic resistance has been gaining attention, especially since it has been found to be one of the hallmarks of cancer. FPIA is a novel radiotracer that was developed for imaging transcellular flux of short-chain fatty acids into the tumor cells as, non-invasively with PET, with a PET scan. It has demonstrated it was demonstrated in our group that in orthotopic glioma mouse models, the FPIA had a high contrast in tumor to normal brain contrast compared with FDG PET, and it also correlated with proliferation and the expression of several lipid metabolism associated proteins, suggesting that transcellular flux of short-chain fatty acids are likely to mediate the uptake of this radiotracer. Now, in the first man study that was done, we had shown that there was a low background signal in most tissues, except in the liver and bladder, which was mainly by the elimination of the radiotracer. And this radiotracer also had appropriate dosimetry for routine clinical use. The next slide, please. So the next part of the Exemplar study was mainly to look at the exploring the utility of this tracer in clinical practice. An additional study that was done was to quantify the magnitude of the early step of fatty acid oxidation in cerebral mets with the use of combined hybrid PET with MRI technology to permit simultaneous acquisition of images from the PET and MRI sequences. Yes, please. Thank you. And a further study is also being undertaken to look at response to tumor response in metastatic renal cell carcinoma with the use of FPIA. Mainly because renal cell carcinoma is quite lipogenic, and therefore we are looking to see the pathway of the short chain of the FPIA in short chain fatty acid metabolism. Next slide, please. This brought us to the main study, which is the FPIA PET imaging in patients with solid tumors. Now, the potential use of FPIA is in imaging response to therapy, a process that is often associated with a change in proliferation or survival. We wish to determine with this study whether the uptake of FPIA is proliferation dependent, which can therefore establish the basis for data interpretation in the future studies of FPIA. This is a study being done at Imperial College, and the primary aim is to correlate short chain fatty acid uptake with tumor proliferation, and the secondary aim is to test for the repeatability coefficient of the tracer. The target group, number of patients that we aim to recruit is 21, and currently we have 4 centers which are 3 centers which are registered with this. That is the Imperial, Royal Marsden, and Guy's and St. Thomas, with different strengths at recruiting specific patients and tumor types, and UCL as our pick site, which is in setup. Next slide, please. So the study involves 2 PET scans done pre-surgery between 2 to 14 days apart in patients who are known to have at least 1.5 centimeter size of tumor lesion, which has not been treated previously and are due to undergo surgical resection of tumor. Presently, as of now, we have recruited about 4 patients from a wide range of tumors. The scans that are done is done. 2 scans are done at base prior to surgery, and the histology from surgery is analyzed for proliferative markers, which will be correlated further with the FPIA uptake. And it's also being done for repeatability at 30 and 60 minutes to evaluate for the repeatability at these 2 time points. Next slide, please. This is a example of an image of a patient with uh, during our governance review of a patient recruited to the study, showing the arrow is pointing to the FPIA uptake in a metastatic node of a vulval cancer, and uh, and also there is the background uptake within the bladder itself that can be seen at just that with the higher uptake in the bladder. The next slide, please. So currently we have got a number of studies that are ongoing to evaluate FPI in different tumor types. So the first one being FPI in solid tumors, which we are looking at completing the recruitment and followed by data analysis for correlation of proliferation. And also we look at completing the metastatic renal cell carcinoma recruitment, and the FPI in with the PET and MRI study in treatment-naive patients with brain mets who are also undergoing radiosurgery. A further study is also being undertaken to study for FPI in post-operative chemoradiotherapy for patients with primary GBM to see their follow-up while they are on chemoradiotherapy. These studies will accordingly provide more data required to evaluate this tracer as a possible novel imaging biomarker for response monitoring in certain tumor types.
Thank you very much for the kind introduction, and very happy to be talking to you today about the Exemplar MISSION-Fumarate study. I'm Jonathan Birchall. I'm a research associate in the Department of Radiology at the University of Cambridge, working on this hyperpolarized carbon-13 MRI study. But I'm also a member of the NCITA QA/QC core lab. So I'm in a bit of a unique position in that I'm undertaking the study, but I'm also kind of self-auditing myself and analyzing the data, which is interesting to see it from both sides. So hopefully you get a flavor of what the study's about and what the future holds. So firstly, why fumarate for people that aren't familiar with a hyperpolarized MRI? So pyruvate is probably the most widely studied MRI tracer to date for carbon-13, and it's mostly because it's very accessible. It comes immediately after the breakdown of glucose and the TCA cycle, and it can be converted into lactate and bicarbonate and alanine and all kinds of other interesting things. And we can monitor what those things do to look at all different kinds of different stages of the metabolic pathway and how, when they're disrupted in the case of disease, we can kind of monitor that progression. Pyruvate does require an NADH cofactor for lactate dehydrogenase to function, meaning that imaging and spectroscopy might not be as effective in certain disease states where this cofactor is inhibited or not present. So we can use fumarate carbon-13 labeled variant as a complementary biomarker in such cases because its only required cofactor is water. So we can detect it even in environments where pyruvate lactate imaging might not be possible. Fumarate can't easily permeate into healthy cells from the extracellular space where we inject it. And this sounds like a disadvantage, but when the cell membrane is damaged, as we might see in a necrotic process associated with cancer, this isn't true. So exogenously delivered carbon-13 labeled fumarate can be used as a biomarker for cell death by monitoring the conversion of the labeled fumarate that can get into the damaged cells, converting into labeled malate. The initial trials of fumarate phantom imaging at Cambridge early this year yielded pretty poor polarization, and we're still working out why that is. We're in the process of optimizing the build-up and delivery protocol in the meantime, whilst we get some upgrades to our hyperpolarizer, to our quality control module, and so on and so forth. And whilst it's not a direct reference to the MISSION-Fumarate study, I do want to just kindly show some information from some of our collaborators at Aarhus University in Denmark, which looked at fumarate imaging in a ischemic renal injury in a pig. So it gives you a little bit of a flavor, a proof of concept of what we're trying to do and why it's interesting. So very much thank you to Professor Christopher Laustsen and his team at Aarhus for letting me use this data. And you can see that they fared a little better with imaging of this ischemic renal injury in a pig model in January and then May this year. And you can see the results. There are clear differences in the ratio of fumarate converting into malate between the injured kidney, which is on the left of the images that you can see here, and then the healthy kidney, which is shown on the right in each case. Both spectroscopically, you can see there's a malate signal clearly visible in the injured kidney, but only fumarate is visible in the healthy kidney, and also in the MR image, where there's a much higher ratio of malate to fumarate in the injured kidney, where of course the fumarate can get into the cell membrane across that damaged membrane and then undergo that conversion process. So where we're going to go from here, I mentioned that we're kind of upgrading things, but here's how I might get there. We've done a toxicology study, which has assessed biocompatibility, toxicity, mutagenic potential, etc., in Sprague-Dawley rats, and there was no serious adverse reactions observed. We have ethical approval for a human healthy volunteer study at increasing injection rates of 20, 40, and 80 millimolars 3 to 4 days apart, just to determine whether it's safe and whether there's any adverse reactions. And we're applying for an approval license to administer these formulations to healthy volunteers outside the scanner, and then if it works, obviously inside the scanner with the hyperpolarized fumarate to image healthy patients, and then 10 renal cancer patients at Cambridge, and also 10 breast cancer patients in collaboration with UCL as well, hopefully to follow. So that's the MISSION-Fumarate Exemplar study. Thank you for listening, and I'll be happy to take any questions at the end of the session. Thank you.
Yeah, thanks for inviting me to present our work today. I'm an MRI physicist working at UCL Quantitative Imaging Group, and I'll be presenting our work for the NCITA Exemplar 5 oxygen-enhanced MRI for patients with lung cancer receiving chemoradiation. Oxygen-enhanced MRI is a method using inhaled 100% oxygen as a contrast agent and measuring lung function by observing the signal changes induced by T1 shortening paramagnetic oxygen. Yeah, thank you. A recent clinical first-in-man study has shown that OE-MRI together with DC MRI can detect tumor hypoxia and help monitoring changes in hypoxia in response to treatment. Next, please. However, thank you. However, standard OE-MRI methodologies have been established only at 1.5 Tesla or lower because T1 relaxivity of oxygen decreases at higher field strengths and lower the sensitivity. Additionally, lung OE-MRI can be particularly challenging at higher field strength due to the susceptibility from air tissue interface in the lung. And in Exemplar 5, we aim to look at hypoxia in lung tumor and evaluate lung function abnormalities using clinical 3T MRI. We have developed a new OE-MRI protocol using dual echo gradient echo sequence. And as a first step, we looked at feasibility of lung OE-MRI at 3 Tesla with healthy volunteers. And we tested scan, rescan repeatability, and then multi-center reproducibility with traveling volunteers. And finally, we aimed to evaluate the role of OE-MRI in adaptive radiotherapy planning in non-small cell lung cancer patients. Next, please. So as a first part, here are our healthy volunteers result, demonstrating that 3T lung OE-MRI is feasible using our new OE-MRI protocol with dual echo gradient echo sequence, which provided us multiple parameters such as percentage signal enhancement at 2 echo times and R2 star. And the scan rescan results show high intra-subject, intra-scan repeatability, and good sensitivity for smoking status as well. Next, please. Then here are results from, yes, thank you. Here are results from 8 traveling healthy volunteers scanned twice, once in London and another in Manchester from January to April this year. As expected, scan parameters cannot be completely identical between 2 MRI systems from different vendors. In particular, we have found that echo times and bandwidth are hard to match, possibly due to different capability of the gradient systems. So direct reproducibility is hard to achieve, but our result obtained at 4 separate echo times from 2 MRI systems show the expected trend with echo times from our simulation, although we still need to look into individual variabilities. Next, please. Finally, we are now about to start a study with lung cancer patients. We plan to recruit 20 NSCLC patients to undergo 3 MRI scans, including 2 pre and 1 post-radiotherapy. We will do dynamic OE-MRI with inhaled 100% oxygen and DC MRI to produce hypoxia classification maps. Currently, ethics application is in progress, and we expect to start the study early next year. Next, please. With that, I would like to thank our UCL quantitative imaging group members, collaborators, and thanks for your attention.
So thank you for the introduction. So I'm a clinical research fellow in Oxford, and I'm going to give you a quite quick overview of the Exemplar 7 study, which is the FIG study. So this is F-DOPA PET imaging in glioma. So this is a feasibility study all about gliomas. So to give you a bit of background, gliomas are the most common primary brain tumour occurring in adults. They're incurable, and they're traditionally dichotomized by their grade into low-grade gliomas, which include grades 1 and 2, and high-grade gliomas, which includes grade 3 and 4. Now, the distinction between high-grade and low-grade glioma is important, as both entities have very different prognoses and management strategies. All treatment options, which currently include surgery, chemotherapy, radiotherapy, aim to prolong survival, maintain quality of life, and slow the inevitable progression from low-grade to high-grade. The rate of transformation from low to high-grade is variable and unpredictable. So picking up the transformation early on traditional imaging with contrast-enhanced MRI alone is often unreliable. And once transformed, high-grade gliomas have a median prognosis of 14 to 16 months with full treatment. So the hypothesis for this study is that PET imaging using F-DOPA as the tracer can detect areas of transformation within low-grade gliomas. Why F-DOPA? Well, it has a low uptake in normal brain tissue and a better tumour to background contrast ratio, and it crosses the blood-brain barrier. So this study has 3 aspects. The first is the F-DOPA PET CT scan. The second is an oxygen-enhanced MRI scan. And this is a unique opportunity we have to collaborate with Jeff Parker, James Grish, James O'Connor, and Mina, as we've just heard, to test this imaging, which may be useful in the broader neuro-oncology setting, not just in gliomas or low-grade gliomas. And the third aspect is image-guided brain biopsies. So putting all of these imaging modalities together to take biopsies from segments of the tumour before it is removed. The presence of high-grade transformation histologically in each biopsy will be correlated to the F-DOPA uptake and regions of hypoxia from the OE-MRI in 21 patients in a multi-centre setting, including Oxford, Imperial and Cambridge. There are also some translational components, but unfortunately there's not enough time in this forum to discuss all of those. So the FIG study is still recruiting, but I'm going to show you a representative case that we have so far. So this is a 23-year-old female who presented with a seizure and was found to have a right frontal glioma. So on the left, we've got the MRI with flare. In the middle, we've got the MRI T1 with contrast. And on the right is the F-DOPA PET using the 20 to 30 minute sequences. So 5 biopsies were taken from areas with varying F-DOPA uptake, of which 2 you can see and these images on the right hand side. We used intraoperative neuronavigation to plan the biopsy targets preoperatively and also confirm their location intraoperatively, so they can then be linked back to the F-DOPA uptake. The overall diagnosis, integrated diagnosis, was a diffuse glioma and diffuse astrocytoma, CNS WHO grade 2. And comparing the F-DOPA SUV uptake at these biopsy points, found a positive correlation with the cellularity and the MIB1 index histologically, which was indicative of high-grade tumour features. In addition, we also still have the full molecular and genetic markers around grading to analyse, alongside the F-DOPA kinetics from the dynamic PET sequences. So by being able to detect areas of high-grade transformation more effectively, there are a number of potential clinical implications. Firstly, the implementation of F-DOPA PET imaging into regular clinical practice for accurate grading without the need for an invasive biopsy and its associated risks of stroke, non-diagnosis, infections, and death. Secondly, being able to target metabolically active tumour for more accurate grading, as it's well known that tumours are frequently undergraded from single biopsies alone. Thirdly, to be able to detect hypoxia from the oxygen-enhanced MRI could have a role for radiotherapy planning, dose escalation, assessing responses to treatment, and identifying patients that may benefit from hypoxia treatments. And finally, and probably most importantly, is that the early detection of transformation would allow for earlier clinical intervention, leading to an improvement in progression-free survival and ultimately patient prognosis. Thank you.